So we're going to have a bit of a session now, just based on a review of what you guys have done so far on measures and your baseline and data capture, etc. So we'd like you to split into your harms. Are we going to do that? Do you want to talk into that?
Right, so what we'll do is that we will break out into harm-based groups, so all the constipation group and not constipated group, constipation group.
Well, we hope you're not constipated after the food, otherwise there'll be complaints to the management.
Uncontrolled pain, respiratory depression, so I'm sure. So there is a room right at the end of this corridor. There's a big room, so all the constipation group can go there. And because of the challenge with space, so we'll figure out that. But the key, shall I go ahead? Yeah.
Yep.
So the key purpose is that we go back and look at all our measures, data collection plan, and compare and see some of the synergy. What are the similarities? What is the differences? Is it possible to come up with some common definitions around what we mean by different things? So it's just an exercise to look into all your data collection as a wider team and learn from each other. And what we'll do is at the end of the session, we'll come back and hear what are the key learnings. Did you change something in your plan, or how does it look like? Because we want to create a bundle at the end, and we want to create a measurement system. So the more it looks similar, it's much better. So, but that's for you to explore and see what difference you can make. So.
And then we'd like each spokesperson from each team just to give a very fast feedback so that we all learn about the changes that you're making and what you've actually found in your harm groups. So, yeah.
And John will be available for any questions, so he'll be coming to your table. And so if you have any questions, please write down the questions, and John can answer some of those questions, and he'll try to answer some of those questions.
So we just wanted to get feedback from the groups that were working on the relative harms, just as you've been documenting, just as a quick snapshot. So perhaps, where would you like to start, John?
Well, I think we'll start with constipation. And
seems to be a very hot topic at the moment.
Two groups. There were two groups working on constipation, so I apologize. I was a little lopsided on my time with one of the groups. I just have one comment before we get started on constipation. Who knew number 2 could be number 1? Sorry, I couldn't help myself, Avril.
That's obviously a humour that goes right over my head.
I hope not.
Possibly.
That's a mad patient. Okay, so some of the things that came out of the constipation group that I'll just kind of reflect on. I think there's a general agreement on most parts on the constipation definition, an agreement on the diarrhea definition. One of the things I would just challenge the group with is go back and look at your operational definitions very carefully. And if you're starting to see a lot of exclusions or zeros or things like that show up in your data, it might just be that you need to tighten up your operational definition a little bit so that you can kind of see the harms. You might need to broaden it or contract it depending on that. There is a power in this group because it's got, I believe, 10 DHBs working on the same metric. So one of the interesting things as you think through it, if you're basically measuring close to the same thing and you were to combine some of your data together, you can start to get a collective signal as a group across a big swath of the country. So country measures are really They're challenging metrics because it's a little bit different. There's always little nuances in the data, and I heard the group talking about that. Well, we count this, and sometimes we do this, or we do judgment sampling, we use random, et cetera. That will all ferret out over time, but the most important thing is if you have quite a few data points, I mean, if you had 50 data points every, I don't know how often, if everybody's collecting on the same timeline, but if you had 50 data points even a month, that's a pretty large sample, and I think what you will find is that you'll start to find a median form across those data points over time. That's really quite powerful. Now, if you wanted to know if an intervention worked, let's say one of the things that I'll reflect back on was, what about types of laxatives? So there was still some discussion about things that folks were trying at various locations, and this one wanted to use Kiwi Crush, and this one used a different laxative combination. So what if you wanted to kind of see which one worked better? Well, if several sites were testing one laxative combination, several were using another laxative combination, it doesn't necessarily mean it works better, but you can go back out and stratify that data again in very small little subsets. I can show you an example of what that looks like, but it's very powerful as to how you can do it. You can also, if you were going to look for like where constipation occurs in your hospital, so let's say you have groups that are working on surgery wards, groups that are working on other wards, so you could stratify by surgical wards versus other wards, and you would be able to see the prevalence, see what the prevalence was across a whole system in general with OIC. And it just helps to get you an idea of where you need to concentrate and where the hotspot areas are within your various organizations. So, a couple other things. Diarrhea operational definition remains challenging.
Not if you ask a patient.
That's correct, yeah. And that might be something as a challenge for your harm group to kind of work on is how would a patient define diarrhea? And if you can come up with a standard way to ask that question across all your patients, let them actually define that harm themselves. And then if they think they had diarrhea, if they didn't, I mean, we can all be technical about it, but at the end of the day, if the patient thought they had diarrhea, they had diarrhea. So whether it's overflow or not, maybe not important. I just challenge you with that. So there were some discussions about, is this overflow diarrhea or is it not? That might be important from a technical treatment standpoint, but a harm is a harm is a harm. So overflow, it doesn't impact your treatment. What it does is impacts that you're still having a harm in the population as a balancing measure. Patients who refuse laxatives. So this might be an area where you might want to consider using this either as an exclusion, unless you have very high refusal rates, and then you might really want to ask the question as to why. I can remember a long time ago we were doing an improvement project, and we did it on flu shots, and one group, that was before we counted exclusions of flu jabs as basically that they got their jab. So we had a group that was there was some incentive in it, unfortunately, and the group basically I noticed that 60% of their patients had refused a flu jab. So it's not really what we wanted. So now we include the exclusions. But for this sake, you might, if you have enough patients otherwise that have constipation, you might just consider excluding people who refuse from that sample. It might give you a little bit better data. And maybe even counting those patients separately in another metric, just to kind of get a percent of patients that refuse laxatives per week. That might be the actual the actual balancing measure. Okay.
So there were two large tables for constipation. So if they could both in turn just feedback what the discussions looked like based on what we asked you to do.
So I guess that we all identified that initially we had challenges with establishing our baseline, and our baselines ranged from about 39% to, well actually less than that, 7% to about 57% across our different sites. There were some issues right at the very beginning that we all shared around poor documentation of bowel activity, people not knowing where or how to document. So it was really hard to identify constipation when you couldn't find out when the patient last had a poo. We wondered about the post-discharge problem of constipation, and in fact with our really short length of stay, particularly in one of our pilot sites as a short stay surgical area, they've often found constipation on follow-up phone calls rather than actually during the course of the audit. And we also wondered if there was a place for following up and rehab for those patients that are transferred from acute services to rehab. So many of us actually had limited our sample groups to people who were in hospital for more than 72 hours. The other things that we found interesting, pre-hospital status. So in fact, was this person at risk of constipation or constipated when they came into hospital? One site actually had some pre-elective surgical laxative use, so the orthopaedic surgeon prescribed laxatives to elective patients prior to them coming into hospital. And we also had a bit of discussion around clinician knowledge of opioids, not knowing what medications actually fell into the opioid group or even what the risk of opioids were. So one site had done some really interesting pre-knowledge assessment from doctors and nurses around constipation. We had a bit of a discussion about laxative use, and that kind of comes in here, interventions. So there's one place that's actually supplying Kiwi Crush on the breakfast tray, and they're then going, well, does it work or not? So we really need to audit whether that's an effective strategy for preventing constipation. Many of us had a common theme around the concurrent prescribing of laxatives and opioids, but then also how are they administered? And then there was a discussion about, are they best administered PRN or regularly, and is waiting 3 days too long before we initiate laxative administration. There's some places doing a lot of stuff around education, also patient information and self-monitoring pamphlets, and there's a really cool self-monitoring pamphlet over there from Counties Manukau, I think it is, where the patient actually has a little bowel chart that they fill out for themselves. Laxatives, which laxatives to use, and whether we have a protocol or pre-printed leaflets for or stickers to go on the medication chart. We kind of explored the whole idea of patients as partners. One place said they couldn't afford to put prunes or Kiwi Crush on their breakfast trays, but could they encourage patients to bring fluids and fruit into them when they come in electively? What does constipation mean for patients, and what do they do about it normally? We all had some fairly common balancing measures, the percentage of patients with diarrhoea, which we kind of noticed has been quite small in terms of total numbers. We had all explored the idea of using pain as a balancing measure, but it was just too challenging because there's too many variables. A patient might be receiving opioids or only receiving one dose of opioids. What does that mean in terms of constipation versus pain? We thought about readmissions related to constipation as well, but once again, that's one of those ones that's at the risk of coding in terms of being able to detect. I think that's everything.
Thank you, Sandra.
We discussed quite a lot of the issues that have already been picked up by yourself and by the previous group. We had quite a bit of discussion around what each group was doing and the differences between us. We were also quite struck at the similarities between the low rate of constipation, which for most of us I think was less than we expected. So when we were actually measuring it, sort of a bit of difference there. But for 2 or 3 of the DHBs, we were going, oh, this is quite surprisingly, or we're not detecting it. It seems to be a low rate. We talked a lot of a reason around whether we had balancing scores. We talked a lot around whether we could look at pain with all the factors that go into that. And some of us felt that your points around that actually with all the sort of the biases will even out in the end, and we really could use that as a balancing that and other things as balancing scores, pain scores. We talked about the pretty consistent definition of constipation that we've all got there, 72 hours. We did talk around whether that was true for everybody. Is that a common, or do we pre-admission? What's the pre-admission situation? And we again sort of not many of us capture that. I think was the consensus. But I think one hospital does. They sort of ask on pre-admission. Come on, guys, say yes or no. Yeah.
Yeah, there's one thing, sorry, getting it on the ADP, and there's another thing actually getting anybody to fill it in properly. So it'd be really interesting to know if they do or not. Actually, that might be something you want to look at.
And
Oh,
we can all think of instances where pre-admission was done 3 months before admission. So
You walked into that one, come on. Yeah. You should know better.
We talked around how each group samples, and there was a Wednesday poo team that goes on to a ward every Wednesday, and that's...
You can take that back to America, okay? You can add to your joke repertoire.
So there are slightly different strategies around that, depending on who's working where and what sort of other commitments they've got.
Those mad Kiwis.
We talked around the definition of a laxative, and Kiwi Crush cropped up yet again, and talked around patient information and how we could perhaps get the patient more involved and help us define things like, has already been set, diarrhea. I'm trying to think of anything else that really I can add to whatever other people have already said. It's really consistent. Thank you.
Well done.
So we're looking at uncontrolled pain, which we found this a really useful exercise actually. So we looked at the similarities and differences between what we were doing. So our aims are essentially the same in terms of what we're trying to achieve. Our outcome measures, we're both looking at using pain score to obviously look at uncontrolled pain. We do both, hospitals use different values for the scales, so out of 5 and out of 10, but we felt that if we needed to combine, that's quite an easy task to do. We are looking at pain scores being measured over a different time period, so we're looking at over a 24-hour period compared with a 72-hour period for the other team. Our balance measures were similar in that we were both looking at respiratory rate and sedation score, but also one of the teams were looking at constipation as well. Our process measures were quite different because of the different interventions that we're having. So we at Canterbury are looking at influencing prescribing. So we're looking at prescribing and administration as process measures, whereas the other group are looking at frequency of pain scores, the patient experience, and whether analgesia was offered. So that's quite distinctly different. Our data collection, again, is different in terms of the time period that we're doing it over, and also the number of charts per week they're actually collecting. So we'd negotiated with Prem to do 7 charts a week, but I don't believe the other group have come to any conclusions as to how many they're going to do.
Thank you. Do you have a question?
I just want to mention a couple of things about the pain group. We on time? Okay. A couple of things about the pain group that came up that were kind of interesting. One was the use of Likert scales. Is everybody familiar with a Likert scale? 1 to 10, 1 to 7, 1 to 5. And so if you have the data guide or the healthcare data guide, it's on page 47, which we now know. But there's a really good example of how many points do you need to sample. That was another question that came up about how many charts do you need to sample and things like that, and how do you get clearer data as you sample more charts. And the truth is, yes, you do, but there's also a point of diminishing returns, if you will. And so just something to keep in mind. In general, between 5 and 10 points is generally pretty good as long as you're able to find the signal. And if you can't find the signal, again, we're allowed to use bias here. You're allowed to use judgment sampling. So try to go where the energy is, so to speak, around or where you think the energy is going to be. You might find out there isn't any, but go look for the source, if you will. And that's a form of in science we call it in scientific studies we call that stratification. We're just doing it on a very guttural level within improvement science using judgment sampling. It's just a way to stratify, if you will. The other thing that I alluded to was we were talking about. Now I lost my train of thought. Avril?
We were talking about pain.
We're talking about pain. Oh, yeah, important. Sorry, a little absent-minded professor action. So with pain, what I'm noticing is that We're seeing teams using balancing measures and also using process measures, and one group's process measure or outcome measure, is a balancing measure for another group. So it might be a good idea to kind of share and contrast, because you can actually leverage the power of your work across the whole nation. And in effect, you'll be checking a balancing measure, but that balancing measure will be an outcome measure for some other group somewhere else. So it's kind of an effective way to do it, actually. Just kind of dawned on me that's what was going on. So that's kind of nice.
Thank you. Okay, respiratory depression.
Rightio then. We are on the respiratory depression, and we had a really, really good discussion about it, because thinking about constipation, everyone has it nearly. But with us, with the respiratory depression team, we were worried about catching these people who do have respiratory depression and how we're going to catch them. Within the last 12 months, taking South Canterbury as an example, we've only had 3 recorded respiratory depressions that needed naloxone use. And we're just working through the notes at the moment. I think Northland was saying it's like one every 8 days. So we have a very wide range. And just taking on what Dr. Cougar was saying about respiratory depressions. Who was it on the pain teams looking at respiratory depression? Can we have your data as well, please? Thank you. So we were, lots of similarities between in our discussions was around recording of respiratory rates, sedation scores and things is not that good. Some of the early warning sheets that we do have around the hospitals don't, the bit that we need is on the back of the page. And people don't like turning over pieces of paper, so we're going to have a look at the early warning scores. And it's about recording and identifying it. The other next thing is about acting on it, as in how do we act on it? Do we have like a protocol, processes? Do we have to call the Quad 7, the emergency team in first before we treat it? And it's also, we've had a good discussion around how do we record things like naloxone use, because we do have some naloxone being used for the opioid-induced itching as well, so it's about separating those out. And just at the end, we're talking about education. But the main things that we want to look at is getting the recording consistency done, looking at how we can record naloxone use, because that's one of your identifiers, and making sure we do capture these people. So at South Canterbury, we're catching our data through clinical coding. Is that the best way to do it?
Thank you.
Okay, so I suppose where we started was we were looking at nausea and vomiting in relation to opioid use in the post-operative period, and we made an assumption that we would reduce the harm to patients if we intervened at that particular time. But just picking up on what one of the constipation groups said, and where we've sort of ended up is that we're looking at that whole sort of pre-operative assessment right back at the health assessment that's done before the patient even hits the organisation. And so we've changed, or we modified our process measures and our balancing measures to some degree. Our outcome measure is still that we want to reduce our nausea and vomiting for patients in relation to opioids. So we're starting to now look at, did the patient actually have an assessment? The second process measure is if they were assessed, did they have a change in treatment? So rather than just looking at antiemetics, some of the discussions that we've started to have with particularly anaesthetic consultants is that prescribing medication is not the only means of altering the outcome for the patient. So you might use different types of anaesthesia, etc. So we're sort of starting to broaden that out. Our next one is if they were assessed and did have a problem, did this information actually get through to the ward and was it actioned? So for instance, in some of the clinical reviews that we've done, we've seen that patients who might have identified themselves in their own health assessment, does that information actually get right through to the end point, and does it get to the staff, and are they actually using the information to reduce the harm to patients? And the answer is no. And so balancing measures, of course, are things like constipation. We would want to make sure that our rates of constipation are not increasing if we're increasing the use of antiemetics, because that is one of the other effects, and that we haven't got increasing pain because, in fact, we're too scared to use our opioids. So that's just another balancing measure for us to be thinking about. So that's pretty much where we've got to, refining them.
Sounds good. All the learning. Thank you.
Hi, I'm Anna from Wanganui, and we joined a group from Auckland, Taranaki and Northland because we're a bit directionless at the moment. So we joined the Auckland, Taranaki, Northland group, and Northland are doing something quite interesting that they're doing a DHB and a PHO collective, which I thought was very good. And we're looking at discharge. So essentially patient stories, what medications are being taken in the last 24 hours, and looking at appropriate...
Before discharge.
No, when they ring up.
Oh.
Yep, if they've taken any opioids in the last 24 hours. Looking at appropriate opioid prescriptions, are they taking others at the right drug amount, etc. And one story that was shared is that when they were ringing people up, they were finding that they had people discharged on slow-release tramadol, and yet they'd never had it in hospital. So it was quite interesting. They're looking at harm as a collective from opioids, so nausea and vomiting, constipation, increase in sedation. And the sort of general aim was discharge information about opioids. Auckland have written a discharge opioid information sheet, which is in draft form, which they've kindly shared with us. And they're looking at the process of writing discharge opioid prescriptions by the junior doctors. So that's sort of where our discussions all led to.
Great, thank you. One.
Last point.
We're running out of time.
Okay. So the question came up about Likert scales, which, sorry, before I lost my train of thought earlier, I was going to bring up. So, so the important thing...
I'm standing right here, John.
So the important thing with Likert scales is that there is also a law of diminishing returns with a Likert scale. So if you're using that within your organization, at about 11, it doesn't help to go to 12 or 15 or 25 or 50 on a Likert scale. It should probably be ideally between a minimum of 5. Ideal is probably right around 7. Even though there's not a ton of evidence for that, there are a few papers written on Likert scales. But because the data is somewhat fixed, with the within that scale parameter, it just gives you a little bit more room to root out variation. But if you're getting 5 points, if you're sampling 5 and you have 7 points, you have anywhere from 0 to 35 points. You could take an average, or you could take the total points for 5 patients, however you want to do it, essentially. But most people will choose an average. But in essence, you have 35 points. That you can see some variation in. You're probably not going to see a lot more if you go beyond that. So, just kind of a word about Likert scales for what it's worth, because you'll sometimes see Likert scales 0 to 100. There may be a few applications. One is functional scores, that they use Likert scales that go up to between 0 and 100. But and they have been validated. But I would just say that I don't know that there's a lot of. I'm not aware of any head-to-head trials that compare, for validation purposes, that compare a 0 to 10 functional scale with a 0 to 100. They just did it so they get a little bit more granular detail, because the effect is so small. But with pain, you're probably okay with those.
Thank you.
Yes, ma'am.
And thank you, everyone, for sharing your learnings and your discussions, because that's really a big part of what we're about for these 2 days, is bringing you all together. It's really nice to see that the vast majority of you have managed to bring most, if not all, of your teams, because that's the power of all our learnings over this time. So thank you.